Shall we start?
Yeah, sure. We can
Okay,
start.
right. Okay,
Okay.
right.
Thank you and good evening, everyone. Thank you for joining us this Sunday evening. I would like to welcome you for this CME session, which is named Hygiene as a Cornerstone of Occupational Health and Safety in Primary Healthcare. The CME today is organized by the Occupational Health Subcommittee of the College of General Practitioners of Sri Lanka. Dr. Kala. I will be moderating this evening's session. Few things, just please keep your mics turned off, but please feel free to send any questions that you may have on the chat. And we'll have time at the end for you all to ask any questions as well. And CME points will be awarded for those of you who have registered and who are there during the talk. Now I have the pleasure in introducing the speaker, Ms. Nira Cooray. Nira Cooray is a safety and health professional who has helped preserve the health of Hawaii's workforce for over 30 years. In 2011, she founded Apex Environmental Safety and Health, a consulting firm that provides ongoing health and safety support to business owners in construction and general industry. Prior to starting Apex, Nira was a senior consultant at Bureau Veritas, where she managed a portfolio of clients and provided them with environmental safety and health consulting services. She began her career at the Department of Labor and Industrial Relations as an environmental health specialist at Hawaii Occupational Safety and Health Division, HIOSH, where she received a Superior Performance Award in 1994 for her work in the enforcement of occupational health regulations. She also worked as an OSH advisor to HIOSH, where she provided outreach in health and safety to small businesses. Nira holds a Bachelor of Science degree in Chemistry from the University of Peradeniya and a Master of Science degree in Chemistry from the University of Hawaii. She also completed a master's degree in public health with emphasis on environmental health at the University of Hawaii. She is a certified industrial hygienist with the American Board of Industrial Hygiene and a certified safety professional with the Board of Safety Professionals. Until 2021, she was an instructor for the industrial hygiene courses at Honolulu Community College for over 20 years. Since 2002, Nira has presented at each ASSP Biennial PAC-RIM conference. In 2008 and 2018, Nira was the president of the American Industrial Hygiene Association, in Hawaii. Nira was 2022 Hawaii ASSP Lifetime Achievement Honoree. Quite a lot there. Nira has lived in Hawaii for over 40 years, but she and her husband are currently in North Carolina near her daughters and granddaughters. She also has a daughter who lives in Omaha, and she's got a granddaughter and one more grandchild on the way. So we're excited to hear what you've got to say. Over to you, Ms. Nira.
Thank you very much. We'll start off talking about the hygiene and the relationship to occupational health to begin with. And then I will do some case studies at the very end. So what is occupational hygiene? It's a discipline of anticipating, recognizing, evaluating, and controlling health hazards in the working environment with the objective of protecting the workers' health and well-being and safeguarding the working community at large. That's the definition from the International Occupational Hygiene Association. So we anticipate, we recognize, we evaluate, and then we control. There's 4 aspects to this. So occupational health is related to the prevention of occupational disease, and exposure is most often chronic in nature. So there's 2 kinds of exposures. You can have a huge exposure in a short period of time, especially like during a spill or something of that nature at work, or you can inhale or get exposed to a small amount of a etiological agent over a long period of time, such as asbestos fibers or any kind of a particulate or a solvent over a period of a career and develop a disease later on in life. That's more chronic in nature. Occupational safety is related to more imminent safety hazards that are like falls, struck by, caught in between, or electrical kind of things. And those are acute in nature and result in imminent harm to health. So we look at a work activity in a workplace setting, and there's exposures going on from that work activity. And those exposures can lead to disease, like I said, and that's where occupational medicine comes in, where we find out ways to prevent the disease. Occupational hygiene, on the other hand, will evaluate, anticipate, recognize, and evaluate those exposures and try to quantify those exposures to see whether the risk is leading to disease. Combined with these two facets is occupational health. So it's a combination of occupational hygiene and occupational medicine. There are several exposure pathways that a worker can get exposed to during a workplace setting: skin absorption, inhalation, ingestion, and injection. Skin absorption sometimes is common when a particular etiological agent can be absorbed through the skin or through the eyes and gets into the bloodstream. And we all know that the bloodstream will circulate throughout the body, and the particular etiological agent can go to the target organs that it is causing damage. So there could be immediate effects in the eyes and skin with skin absorption. Inhalation occurs by absorption of particulates or chemicals through the lungs. So we can get, we inhale it, and it can go into your lungs and maybe deposit in the lung lining or get into the bloodstream with the blood exchange in the alveoli, and then go to the various target organs. Ingestion is also possible when there's poor hand hygiene practices, when employees are smoking, chewing tobacco, or eating during work or drinking with contaminated hands with the particular chemical. They can ingest a small amount through a period of time. And I have seen this over and over again in construction, where they handle contaminated soil and they are eating and drinking without washing hands and maybe ingesting small amounts of lead and other metals that are in the soil that's contaminated. Injection is a more rare exposure pathway. It could happen when handling contaminated tools or equipment and other items capable of causing punctures, cuts, or abrasions in the skin. And then there could be exposure through these wounds. Occupational diseases, on the other hand, can be caused with chemical agents such as gases, vapors, solids, fibers, liquids, dust, mists, and fumes, and physical agents such as noise and vibration, heat and cold, and radiation, biological agents such as bacteria, bloodborne pathogens, fungi, etc., and ergonomic factors, lifting and repetitive motion, and psychosocial factors of stress, workload, and work organization. When you look at chemical agents, there are several facets for it. There's dust and particulates, there's metals, there's vapors, there's gases, there's pesticides, in particular organochlorine, organophosphate, and carbamate category pesticides that are in use. And these are some of the disease-causing etiological agents that we see in the workplace. Diseases from metals, noteworthy is lead. And here we have regulations to prevent all these occupational exposures by Occupational Safety and Health Administration, which we call OSHA. And they have two sets of standards for general industry, actually three: general industry, construction, and maritime. They are listed under 29 CFR 1910 for general industry and 1926 for construction and 1915 for maritime. And they have regulations to prevent exposures to lead and chromium and arsenic and so forth. So there are particular metals. Cadmium has a specific standard for it. And to come up with a standard for OSHA, I say standards are written in blood because one has to propose a rulemaking process And NIOSH has to do a lot of research to show that there's significant disease caused by this etiological agent, and they have to show some statistics related to that. And that's when OSHA agrees to propose a rule, and it's published in the Federal Register for comments. And then there'll be a lot of comments from the manufacturing part and the labor unions and so forth. And these comments will go back and forth. And finally, the language will be decided and an occupational limit will be promulgated based on the research, and a standard will be promulgated. So it's a long-standing process. And when there's significant damage done by a particular etiological agent, then there are standards promulgated to prevent exposures or prevent disease. Vapors are coming from solvents, mostly, I have a typo here, ketones, alcohols, and things like that. Side effects are CNS depressants. They can cause dermatitis, some damage to the peripheral nerves, some damage to kidney and liver, some interfere with blood formation, and some can penetrate through the skin. And some solvents can decompose to toxic compounds during heating. And methylene chloride is a special one. It has a substance-specific standard as a solvent. Chlorinated solvents are more notorious. The more chlorines you have in the solvent, the worse it gets. So gases can be simple asphyxiants or chemical asphyxiants. Simple asphyxiants are gases like nitrogen that can displace oxygen in the air and become an asphyxiant. Chemical asphyxiants can be carbon monoxide that can interfere with making carboxyhemoglobin and interfere with oxygen uptake in the blood. Irritants can cause bronchitis and pulmonary edema. Hydrogen sulfide, sulfur dioxide, ethylene oxide are some of the gases that are more prevalent in the workplace. Ethylene oxide is used as a sterilizing agent in healthcare setting, and hydrogen sulfide you can see in refineries and so forth when you process sour crude. So there are toxic gases also like chlorine that interfere, and carbon monoxide with interfering with oxygen take up in the body. Physical agents can be noise, and noise-induced hearing loss is very prevalent in the workplace. Vibration due to jackhammering and other equipment that causes vibration. Ionizing radiation and non-ionizing radiation, which there are no regulations for OSHA. And for heat stress, there's only an advisory by OSHA for heat stress, and there isn't anything for cold stress. Biological agents can be viruses, hepatitis A, B, and C, HIV virus, bacteria such as anthrax, leptospirosis, Legionella, and there's no standards for moles. And then there's histoplasmosis and farmer's lung and other allergens from pigeon droppings and moldy hay kind of thing, and plant poisons such as ivy. So psychosocial causes can be people's lack of physical and mental fitness and inadequate training or skills, and work demand, long hours, shift work, repetitive work, and the environment they're working in with the noise, humidity, and other factors, lighting, and poor industrial relations, communication, and supervision can be factors for psychosocial issues. Let's look at the relationship to occupational hygiene. So we're looking at some industrial processes here. When we look at building, which is done construction, I can say none of the buildings that you occupy can be constructed without the process of welding. And welding requires using rods when you're using steel welding or what we call stick welding. And the rods have a compendium of metals, starting with nickel, arsenic, manganese in particular, and especially if you use mild steel, which we call 6018 or 7018 number rod. There's a lot of metals in the welding, and the welding fumes in itself is a fume that can become particles when you cool it off, and deposit in the lung, and welders have welding fume exposures, and we call it metal fume fever. And you go home on Friday, and then you call it the Monday morning fever because you feel like flu-like symptoms coming on Monday due to these exposures. And there's other gases and vapors coming out of welding, and also UV radiation coming out of welding. Sandblasting is also happening a lot here. There's a lot of silica exposure. I know that quarrying is happening in Sri Lanka, and when you're doing a rock quarry and breaking rocks, there's silica coming out from these quarries that can deposit in your lung lining, can cause long-term exposures and cause silicosis. There's a lot of noise during rock quarrying and repetitive motion injuries. So the evaluation part is where the hygienist comes in, and we go in and we try to quantify these exposures through measurement. So there's measurement methods prescribed by NIOSH or OSHA for each one of these etiological agents. We look at the safety data sheet or the process and come up with the anticipate with the possible contaminants that might be present. And we look up the evaluation methods that are prescribed by NIOSH and OSHA. Usually it's hanging a pump that is running at a prescribed flow rate. The pump is connected to a Tygon tubing, and the Tygon tubing has some kind of a media, which is like a cassette or something that's attached to the employee's breathing zone, where we collect a sample during an 8-hour work period and send it to a lab. And when the results come, we know to quantify how much of silica or how much of particulate or how much of vapors was in that work environment during the 8-hour shift. And then we compare it with the OSHA's promulgated occupational limit, which is called the 8-hour PEL, permissible exposure limit, where OSHA says that a worker could get exposed day after day during an 8-hour work period for a 40-hour week and not have any adverse health effects. So that's kind of the limit we compare it with. And if it's below, then there's nothing to worry. We say the risk is manageable and the subject employee will not develop disease in the long run. But if it's at or above the exposure limit during the evaluation, that's when we come up with controls. And in occupational medicine, we have to have applied the basic principles of occupational medicine to your practice as doctors. So ask the questions in order to take appropriate and relevant occupational history and to identify patterns in the patient's history that may indicate work-related contribution to the ill health. Consider work-related health dilemma to reach a conclusion with reasons. And you can list with causative agent and related work activities for an occupational disease. Specify what information is necessary to make a fully informed assessment of the individual's medical fitness for work. So here, we look at your history from graduating from high school to present. Where have you been working? Have you been in the military for a period of time? So what jobs have you held? And where are you working now? Has there been any changes in your production process? And describe to me like a typical working day or a week. As a hygienist, I interview the employee and usually ask these questions like, tell me what you do when you come to work and clock in, and where do you work and what do you do normally? So then we look at the layout of the workplace, make a diagram, what equipment they're working with, what chemicals they're working with, or what products they're working with. So there's those kinds of things. And then it's important to ask what hobbies they have. Sometimes they can get exposed to certain etiological agents due to hobbies. Once I was in a workplace where all the employees were testing lead in their blood and they didn't know how it was happening. And we looked at it and there was no lead used in the workplace. And we found out that most of those employees are making fish weights called vari weights at home for the fishing hobby. And so those weights were made with lead ingots, so they were melting lead at home and making lead weights at home, and that's how they got exposed. And they bought the shavings of the lead in their work clothes to the workplace, and it was all on the lunchroom table. When we wiped and sampled the lunchroom table, it tested positive for lead, so they were bringing it from home. So it's important to know what they're doing at home and what else they've been working with. So they can come and say, I'm a welder, or I'm a construction worker, or I work in manufacturing, I do metal work or whatever. And then you can ask, what is your day like, and what chemicals are you handling, and how long are you doing each thing? Are you working with any tools that make noise, and so forth? So we're also looking at the history. What symptoms are you having right now? Why have you come to see me as a doctor? Because you are ill. And what kind of symptoms do you have? And how long have you had it? And so forth. And are you aware of any respiratory sensitizers at work? And how does the symptoms develop? Is it immediate or is it delayed? Does it improve when you stay away from work? And it's important to ask about the smoking history and history of atopy. I won't get into control that much. I will just show you one slide about the controls, because when we come up with the controls, like I said, when we are above the PEL, we try to eliminate the hazard first. We try and see whether there's a substitute chemical that's less hazardous that we could use. Or we could eliminate the hazard by, if you're spray painting, can we brush paint? Can we change the process? Engineering controls most often is used. It's local exhaust ventilation. It's putting an exhaust pipe right over the breathing zone and sucking out all the contaminated air from the breathing zone, which is an expensive option and not usually viable in construction, because things change day to day and the work processes move in a construction site. So engineering controls is not that feasible in construction. Administrative controls is training, some other things that you can do, like changing the work process and so forth. And your last resort, when nothing else can bring the exposures down, is to resort to personal protective equipment, abbreviated as PPE. So then we give the employee to don a respirator. We can give the employees to don gloves, respirators, and so forth to prevent skin exposures and inhalation exposures. So I won't go through the other control slides due to the interest of time. Where the doctors can make a contribution is when we look at medical surveillance as a control. So what if you have an individual in the workforce with a heart condition being exposed to a drug substance that causes an increase in the heart rate? So the employee already has arrhythmia, and there's a particular substance they're getting exposed to, and you can look at that kind of thing. Or there's a pregnant employee that's working with a substance that is known to have teratogenic side effects. And sometimes you can have an employee that's highly allergic to a product you're manufacturing to the point that it may cause anaphylaxis. And this has actually happened in Hawaii in a vocational training center. And they were right across a big hospital called Kuakini. And the particular employee was particularly sensitive to formaldehyde. And they were bringing this fabric from Indonesia, and they were cutting this denim fabric and making clothing products. And the employee got exposed to formaldehyde and went into anaphylaxis. And by the time she was just crossing the street, getting to Kokini, she died. So she had a very strong reaction to that particular agent. So sometimes these kinds of things can happen. And the above questions emphasize the need for a medical surveillance program. So sometimes there's a questionnaire that's administered during the intake of the employee or during a hiring process, asking these questions. And here, because of the regulations and the workers' compensation rules, there's these practices in place in many workplaces. So annual health examination, sometimes you create a baseline, especially when you are going into a manufacturing facility that has noise as a particular uh, agent that can cause hearing damage, because the workers' compensation here for noise-induced hearing loss is very high. If you have hearing loss, you can get as much as $100,000 from the employer as damages. So most employers will conduct a baseline hearing audio-based testing when you're hired for your right ear and your left ear and document it, because they want to conserve that hearing over the period of time. And every year they do the audiometric testing to see whether your hearing is the same or is it going down. So we'll talk about it in a case study that's coming up. And sometimes they do biological monitoring, which is testing your urine to see whether there's any metabolic products of a particular agent that they might be getting exposed to, chest x-ray and electrocardiogram, and sometimes extra blood chemistry. And lifting nowadays, because there's no ergonomic standard, is kind of regulated a little bit because of the workers' comp. Many jobs will say you must be able to lift more than 50 pounds. And if there's a lift task, they go through that. So here are some case studies that I came up with. So the workers are stripping some lead sheath copper cabling in sheds with inadequate ventilation, putting them at high risk for lead exposure. Workers were eating and changing out from their contaminated overalls in the same area and were smoking on site, which raised the risk of them ingesting significant amounts of lead. And an investigation found that between October 2008 and July 2009, more than 90 workers were significantly exposed to lead as a result of this process. So what should be done next, in your opinion? Anyone? So what they must do is to test the blood lead levels for lead, because the lead standard requires that if your blood lead level increases more than 40 micrograms per deciliter, then the employer has to remove that employee from that work environment. It's called medical removal protection. And they have to be given the same pay, and you can put them in another job that doesn't expose them to lead. For example, let's say we have a painter that's sandblasting a lead painted bridge, and his blood lead level is exceeding the 40 micrograms per deciliter. You got to give him the painter's salary, and maybe he can flag the trucks coming in and out of the construction site by the gate, or do something like that that doesn't expose him to lead. But what employers normally do here is, it's against the law, but when they see it coming, they lay them off, saying, work is getting slow, so we are reducing the workforce, so you're laid off. So then they don't have to do the medical removal protection, because they lose money when they do this kind of thing. But it happens sometimes, and people have complained to OSHA, and we have investigated, and the law says that you have to do the medical removal protection, and then send the employee to chelation therapy, to occupational medicine, where they give ethylene diamine tetraesteric acid, EDTA, chelation, to remove the lead from your system. And then you monitor the blood lead until your lead level is below the 40 micrograms per deciliter. And then you can come back to your job. So, and this has to be paid by the employer for chelation therapy and so forth. So this is part of the lead regulation, which is the 29 CFR 1926.62. It's a huge standard that has a lot of details about the permissible exposure limit for lead is 25 micrograms, I think, per cubic meter when you measure. And if you go above 50, which is the PEL, action limit is 25. At 25, if you work 30 days a year on that job, then you're required to have medical surveillance training and some requirements. But if you go the 50, then we have to do engineering controls and do all that. And giving personal protective equipment is not allowed as a first line of defense, only if you can show that you did engineering controls and other methods and it's not capable of reducing the exposures below. That's when you're allowed to provide PPE. So that's one method of doing it. Now, another one is an unknown chemicals field. So a 22-year-old male employed by a company that manufactures ink dropped a bottle of compound X, saturating his right leg, right side of his stomach and his chest. Fellow employees immediately removed the shirt and threw water over the upper body, and the victim then walked across the street to a doctor's office without any difficulty. However, within 15 minutes of arriving at the doctor's office, he collapsed and died. So what could this possibly be? Autopsy revealed extensive first and second degree burns on the right side of the body, right arm, right leg, and scrotum area, where there was edema in both lungs, kidneys, pancreas, and spleen. So the ink had a particular chemical that went through the skin and immediately caused this reaction. So what could it be? So the culprit is phenol. So phenol is one of those chemicals that can have immediate effects. I've seen an incident where there was a tanker truck that was parked in the winter that had phenol in it, and the phenol was frozen, and they had a insulating jacket that was getting warmed up so that the phenol can be melted. So they heated it up quite a bit, and the thermometer was showing that the phenol was not getting defrosted or melted. So the employee went up the ladder to the tanker truck and opened the top of the tanker, the lid, and looked inside. Then found out that the thermometer was malfunctioning and the phenol was actually gurgling. And when he opened the lid, phenol just burped and doused the employee. And he came down the ladder and he's in the employee's safety shower, rinsing himself out when he collapsed and dies. So this is a true incident, and phenol can have immediate effects in your lungs, causing pulmonary edema and immediate death. So that's another one that one can look at. Like in health, we look at job hazard analysis, breaking the job step by step and looking at all the hazards to see what can possibly happen in a worst case scenario, and then come up with how can we prevent from this happening, and have some methods, training, PPE, and engineering controls. In this case, the employee should have been wearing a full body coverall and not gone with the regular clothing to open the hatch of the tanker. So, and it's anticipating and recognizing and doing a job hazard analysis. All these things come into play when we look at a workplace process. So case studies 3 is related to oil refinery worker who was attempting to repair a valve from a gas that has been escaping. He became dizzy and noticed a pressure in his head and then passed out. A fellow worker who attempted to provide first aid was also rendered unconscious. Both victims began to convulse and then were taken to the hospital immediately. And this was related to hydrogen sulfide exposure, which also happens quite often, that's causing death. So hydrogen sulfide is a very toxic gas, and during sulfur-containing refining of crude oil, this can come out and expose employees to it. And chlorine is another gas that is also very toxic and can cause damage to, it's very corrosive because it dissolves in the mucous membrane in your nose and your throat, and is a corrosive gas. So the first one was apparently on the way to his recovery, but at approximately 72 hours after exposure, developed a severe pulmonary edema and died in spite of all efforts to save him. The second victim recovered completely within 36 hours and was back to work within a week without disability. So this is the one for the oil refinery worker. Now, another one that causes pulmonary edema like that is the metal cadmium. Sometimes there's cadmium coatings in rods and in work surfaces where you kind of weld it or solder it and heat it up, and cadmium fumes can be inhaled. And cadmium has a substance-specific standard in the OSHA regulations, 5 micrograms per cubic meter, which is a very low limit as an 8-hour time-weighted average, and can cause delayed pulmonary edema. So here's a fourth case study. A compliance officer visits a construction site and a worker is seen operating a jackhammer. He's chipping concrete from a parking lot so that the potholes can be refilled. Among other hazards, the safety manager decides to sample for noise. So the employee says he has worked for XYZ company, a non-union shop for 2.5 years. He operates a jackhammer 15 minutes, takes a break for 5 to 10 minutes. He's 26 years old, doesn't recall ever having a hearing test. His supervisor told him there were earplugs available in the truck. The noise reduction rating that was available to him was 29. Everybody knows what a noise reduction rating, right, is for a earplug. It's the amount of decibels that you'll take out if you wear them properly. And here we give a safety factor of 50%, and the OSHA regulation for noise has the calculation when you measure noise, what plugs with NRR will be suitable. So the employee wears them while hammering, but says he still hears a buzz in his ears. And when the plugs are in, he relayed that his wife says he doesn't hear her. Company officials say they know the hammer is loud, that's the supervisor says he does a weekly toolbox training. The employee said he learned how to put the earplugs by reading instructions on the box. So with this, I will show you a video of how noise-induced hearing loss will happen.
Let's listen to what it's like to have sensory neural hearing loss. Perhaps then you will have a greater appreciation for hearing protection. Normal hearing.
77 years ago, our fathers brought forth on this continent a new nation, conceived in liberty and dedicated to the proposition that all men are created equal.
Hearing loss above 2,000 hertz.
Now we are engaged in a great civil war. Question whether that nation or any nation so conceived and so dedicated can learn and do it. We are not.
Hearing loss above 1,000 hertz. Hearing loss above 500 hertz.
The world will little note nor long remember what we say here, but it can never forget what they did here.
Sounds quite muffled compared to normal.
So this is a short clip of what sensory neural hearing loss sounds like. So when we do noise training, one of the big things that we face is to motivate the employee to wear hearing protection. So here in the United States, we have a noise regulation, which requires employers to have a hearing conservation program anytime the noise exceeds 85 decibels. So the 85 decibel limit is a 50% dose that we use audio dosimetry to measure. And anytime it goes over the 50% dose, we explain the dose as like a bucket that's allowed by OSHA to the employees. And we say, when your bucket is full, you have 100% dose. When your bucket is half full, you have a 50% dose. So that's when these actions have to be taking place. So the hearing conservation program has 4 or 5 elements. So one of it is audiometric testing. One of it is training. The training has to show how noise can affect your hearing. And that's why we use this as the part of the motivational video of how hearing loss happens, because most employees will say, oh, my grandma can't hear and she's wearing hearing aids and she can hear fine. I probably can wear hearing aids one day. So we stress the point that there's two kinds of hearing loss. There's conductive hearing loss and sensory neural hearing loss that's related to high noise. And you're not going to get what your grandma has. So this kind of thing cannot be corrected while wearing a hearing aid. So you might have to do cochlear implants if you have to correct it, which is a very expensive proposition. So we show this video, and part of the hearing conservation program is also to have hearing protectors available, not to say like, I have it in the truck. If you want to wear it, you wear it. It's having a policy in place saying you must put it on as you come into work. You have to keep it on and train them how to properly fit it, because there could be leakage occurring in how you wear it. So there's that kind of requirements. And anytime we see employees without hearing protectors, we're looking at whether the employer had a policy, whether it was enforced, and whether it was in place. They can't say employee misconduct, or I told them until my face turned blue and they're not wearing it. It's not something as a compliance officer that I would buy for OSHA. I will say, show me how many times you put notes in his personal file about not wearing it. How many warnings have you given? After 3, have you given a suspension? Was it enforced? So these kinds of things have to be checked when looking at the hearing conservation program, and has to be in place to prevent the employees from losing hearing. And also measurement is very important to quantify how much. And we also have the octave band analyzer that industrial hygienists use to come up with the frequency of the noise. So if it's low frequency, the correction is very hard. For example, if there's a fan going, by reducing the number of fan blades or things like that, you can change the amount of the frequency of that low frequency noise. High frequency noise is easier to correct. Sometimes putting an enclosure around the equipment, or putting the employee in some kind of a cubicle that's putting a concrete barrier between the equipment and the employee. So these are some kind of things that can be done at the employee or at the source, or between the pathway, putting sound absorbing material. So we work with a lot of noise hazards in this case. So that's one of those things that we can do. So here's another case study. A 25-year-old male chemical helper and a reactor cleaner in a plastic manufacturing operation began to experience pain, numbness in hands, and tended to drop objects. Fingers were white and symptoms were worse when it was cold. He claimed that after he finished cleaning the reactor, he would be confused, dizzy, and felt like he was drunk. So the initial diagnosis was Reynolds syndrome, or vibration white fingers. He was then transferred to a different area to the plant that did not involve further exposure to the chemicals in the reactor. Later, the diagnosis was confirmed as acrosteolysis, a condition that involved the deterioration of some of the bones in the ends of the fingers. 20 years later, this man, now 45, was admitted to the hospital with black tarry stools. Although the upper GI series was normal, a tentative diagnosis of bleeding duodenal ulcer was made. 4 months later, he was readmitted for persistent tarry stools. This time, the liver function tests were abnormal, and the liver scan indicated a large lesion of the left lobe extending to the right lobe. And they found out that this employee had something called the angiosarcoma of the lung, which is very specific to only one chemical that I know of, and that is in the plastics manufacturing, called vinyl chloride. So anytime you're exposed to only vinyl chloride, that you can get angiosarcoma of the lung. So this was an important case study again. And I know in Sri Lanka, some manufacturers have the safety data sheets available. They have translated it into signalese and so forth. But some of them have no clue. They are stripping furniture with methylene chloride. They're using these chemicals in plastics manufacturing. And a lot of the hazards are not recognized or evaluated or quantified. So that's something that you can think about. Here's a farm worker. There's a lot of agriculture related injuries also. So a 46-year-old farm worker went to see the local family doctor with complaints of anorexia, loss of weight, hyperirritability, fine tremors in the hands and arms. These symptoms have been gradual in onset and noticed them for at least for the previous 2 weeks. The doctor made a tentative diagnosis of peripheral neuritis from overexposure to farm chemicals. He told the farmer to stop all investigate. So here's what the initial investigation found out. The history of the use of insecticides in numerous occasions over the past 3 years. They didn't wear any respirators or skin protection. The farm worker bathed only weekly. The formulation shed where they mixed all the pesticides and the insecticides had oils, water, insecticides, but it was open to 3 sides to the atmosphere. So it had general cross ventilation. Chemicals found in the shed include malathion, chlorinated insecticides, kerosene, gasoline, paint, and paint thinners. There was no exposure data available. None could be obtained because the operations had ceased. So the doctor's subsequent diagnostics has suggested the presence of chlorinated insecticides in fatty tissues and some liver dysfunction. And his preliminary report to the industrial hygienist, he wrote, hazardous and toxic material exposures from farm chemicals as possible exposure to farm workers' symptoms. So which of the following types of information would an industrial hygienist and the doctor look for during such an investigation? Would you look for the chemicals in the operation and the potential exposure pathways, levels, and possible routes of entry? And would you look for the work practices of the mixing and spraying of equipment and spray operations? What kind of personal protective equipment they were wearing? What kind of training and education was given to the farm worker regarding these? What would you look for? A, B, or C, or D, all of the above? Any takers?
Is it all of the above?
All of the above, correct. So could be all of the above. And so what would you think is the major source for the farm workers' complaint? Malathion intoxication, chlorinated insecticide poisoning, kerosene and gasoline, or hepatitis? Chlorinated insecticide poisoning. So that could be the possible thing. And what does malathion smell like? Oranges, garlic, peppermint, or decaying leaves? Any takers? Smells like garlic. So because I went to a company here when I was in Hawaii, in the neighbor islands in Kauai, and they said they're spraying malathion, but they spray it for about an hour between 5 p.m. and 6 p.m. when the wind is going in the other direction, and the employee can smell it in the cab. So I had to do an assessment and fly to Kauai, and it's another island in the Hawaiian chain. And lo and behold, yes, it was in some place called Koloa, which was about 1 hour from the airport. And this was during COVID time. So I had to go stay the night in Kauai also, because there are no evening flights from that island to our island. So, but the smell was coming to the cab and it had a garlic smell. And when the thing was that there was some kind of a ventilation duct from the cab, and the way they sprayed it, that it came sucking right back through that duct back into the cab. So we had to reroute that ducting to another area so that it doesn't come back to the cab, and spray at a different time with a different wind direction and so forth. So there's malathion spraying going on, and you can look at the various things like that. In this case, the most likely route of entry for the farm worker's body was inhalation, ingestion, skin contact and absorption, or through the eyes. Skin contact and absorption. So a lot of the pesticides have skin absorption. So skin contact and absorption is important when we look at farm workers. Now, my dad was a physician, and at that time I was probably 8 or 9 years old, and I didn't know I was going into occupational health, but he went to something called the Colombo Commercial Company every morning in Hunupiti Road in Vatkala, and he was the company doctor. So if he lived now, I would have asked him what kind of cases that he saw in the morning when he went as far as workers and complaints. I know he talked a lot about like dermatitis and people coming with various skin kind of diseases and whatnot, but I was not into occupational health at that time. So in hindsight, I think like it would have been interesting to know what kind of cases they saw there. So anyway, in the long run, what I have to say is if you don't look for it, you will not find it. If you don't find it, you don't think you have a problem. And if you don't think you have a problem, you don't do anything about it. So there we are. So we have to recognize, anticipate, look for it, quantify it, and see that there is some issue here in the workplace. And prevention is worse than cure. So prevent occupational diseases from happening by taking a proactive approach in looking at exposures and seeing how you can circumvent it from manifesting to a disease through the various interventions. I know I have a lot of questions, so let's go to the chat. And
there's a question there which is, how do you approach patient requesting medical certificate, saying that he or she can't work at a place assigned and needs another place?
So here there is, I don't know how in Sri Lanka this works, but here there's a thing called reasonable accommodation. So if there's significant hazard that can be approached, then there can be a doctor's note to say that this particular employee is either allergic or this condition is not favorable for his work environment, that he needs reasonable accommodation. I can give you a good example. I did an investigation for immigration's customs employee in Honolulu. And he had stroke-like symptoms when he was scanning these immigration documents in a scanner. So first I was called by the Federal Occupational Health here in Washington, D.C. saying, there's an employee in Honolulu that is hospitalized due to stroke-like symptoms, and this happened twice. Something is going on in his work environment. Can you please find out? So my first approach was to visit him and look at his office, and I thought there might be some formaldehyde coming from the scanner. So I measured the formaldehyde. I looked at his office and what he did, and I found out that most of his immigration papers came from China, and it was like fingerprints, and he was scanning these fingerprints documents and making a database. So then looking at, and then there was, the office was old and he was a hypochondriac, and he said there was cockroach legs and all these insects in his office, and there might be mold and all these things. So one by one, we were investigating each thing when occupational physician got involved. And he called me and he said, Nira, do you know that he's allergic to shellfish and iodine? And immediately I knew what happened. So when he said he's allergic to iodine, all this fingerprinting that he was touching had the fingerprint manifestation powder that had iodine in it. So he was getting a small amount of iodine through his skin, and that was causing him some kind of anaphylactic shock, that he was getting these stroke-like symptoms. So we had to make reasonable accommodation in that case and move him to an area that he didn't have to do scanning and he didn't have to be in that office. So that's typically for a good reason. You can give a medical certificate, but not just because a patient just came and said, I don't like sitting here. I want to sit over there. kind of a thing. So it could be, you have to investigate the reason for it and whether there's some kind of a health hazard or something involving that is unfavorable for that employee's life and health when you do that. So,
Thank you.
anybody else?
There's another question on the chat. I'm not particularly sure what they're asking, but they're asking, what about glyphosate poisoning? Perhaps Dr. Jagat?
Yes.
Yeah,
Yes.
please go ahead.
Controversial subject, glyphosate. Now I do work with Monsanto, which is now called Bayer Crop Science, and they've been sued and they've been fined by the EPA for glyphosate use and everything. And there's a lot of golf courses in Hawaii, so there's heavy glyphosate use, and it's very controversial, the health effects of glyphosate. And there's no regulation per se for glyphosate by OSHA. I'm sure there's occupational limit for it, and it's more an EPA issue for the environment than a employee health perspective. But overall, I can say glyphosate poisoning is for real, and like any exposures, we have to try and manage it to minimize exposure as much as possible. I can look up the limits for you, but give Asini the limits for whatever I have. I don't have it on the top of my head. So,
Thank you.
anything else?
Any other questions anyone has?
Madam, thank you very much for the very interesting lecture. I hope you can hear my question.
Yes.
Right. I'm working at one of the major hospitals in Sri Lanka, the
Yes.
Affection Hospital, Cancer Hospital in Maharagama.
Yes.
Some time ago, there was a concern that some of the radioactive material that we used in certain tests, such as the PET CT, has had some inappropriate, of course, disposal, and there was a hazard of employees being exposed. In such a situation, how would you advise for us to set about? Because this was only exposed after they did certain tests around the Linac building. Unfortunately, I'm not aware of the sequelae, but if we are in such a situation, what would you suggest?
Here in the major hospitals, because radiation is really regulated by the radiation authorities and not by OSHA, but most of the people who use radiation, like the doctors, will wear a badge to see how much of radiation they're getting exposed to. So it's monitored. And when you put it in the trash, all the trash that goes out, the medical trash, goes through some kind of a radiation detector scanner. So when it beeps, you know that there's radiation in that trash. And so that's how they find out, because it usually goes to some kind of a landfill here. And it has to be radiation free. And like the sharps have to be disposed in certain ways. There's disposal protocols that's done by the hospitals. So here there are radiation detectors, and even in the landfills they have, when it comes in, they usually put it through the scanning process before they take it in. So that I think something has to be implemented for the workers, like wearing a badge or putting some kind of a scanner where you detect radiation.
Thank
I
you
recently
very much,
came to
madam.
the hospital. Yeah. I came to the AIHA hospital in January because I had a friend who's a bone marrow transplant specialist who visited me from Honolulu, and he was interested to see the hospital. So we came, and I think one of your doctors gave us a tour and everything, which was very good. And they were amazed at the volume of patients you see for a day, as opposed to here in the US. That was the very interesting thing they said.
Thank you. Thank you so much. If there are no more questions, I think we can wrap up. Thank you so much, Ms. Nira Cooray. It was a very informative talk, and I'm sure everybody has learned quite a bit from it. Thank you so much.
You're welcome. I'm glad I could able to participate. Have a great night,
Have a
all
good
of
evening.
you.
Thank you so
Yeah.
much. Thank you.
Yeah.